My name's Michael Reade. I'm an anaesthetist and an intensive care physician in Brisbane, Australia. I'm very pleased to talk to you today about the use of biomarkers in traumatic brain injury. Although one of the disadvantages of this conference format is that we don't get to hear one another's talks. And I know that in this session, Professor David Menon from Cambridge has talked about personalised medicine. And I'm quite sure that in that talk, he talked quite a lot about biomarkers in traumatic brain injury. So I do hope I'm not going to say anything that contradicts what he said, and I hope also there's no great repetition. I guess we'll see. I have no conflicts of interest to declare, but I would like to express my gratitude to Dr. Nasrallah and Dr. Belapart, my co-investigators in the Predict Traumatic Brain Injury study that in part uses biomarkers. I'm going to allude to some of what we're doing here in Brisbane towards the end of this talk. So biomarkers in traumatic brain injury, what potential use could we put them to? Well, I guess there's a few potential uses. This is one. Many of you will have looked after such a patient, a young male with a low motor score after trauma in the intensive care unit with unreactive pupils who perhaps has been a little hypotensive at the scene and who on a CT scan has quite severe diffuse axonal injury. And there's a number of clinical calculators, and we'll talk about some later in the lecture, such as the impact prognostic calculator, which tell us that he's got a very poor outcome, or likelihood of a poor outcome, 89% in this case. But is that good enough to make decisions? Well, in fact, I could show you evidence that in fact it's not. That very few of us will use an 89% chance of a negative outcome to do anything different other than to continue to support such a patient and see what happens. Potentially biomarkers might help us make a better decision early on in such a patient, or perhaps not, as we might see. Another problem is one that we come across in the military, as you may have seen from my initial slide. I'm an officer in the Australian Defence Force. And here is a patient who's been exposed to a blast injury, an injury that comes with a high risk of intracranial hemorrhage and diffuse axonal injury, and who, with these sorts of observations, we would normally subject to a CT scan to exclude intracranial pathology. But often our soldiers are a long way away from a CT scanner, and it's risky to get them to that CT scan. We know that such a patient with these signs would have a 3% by those risk calculators chance of deteriorating from that point. And it would be good to have a biomarker to risk stratify to see whether it would be worth transporting such a patient to CT. And then the third type of problem is for example, in sports people who may be knocked unconscious on the playing field. And we know that there's a risk if this repeatedly happens, that they develop chronic traumatic encephalopathy. It would be good to have a biomarker early in their playing career to identify people who are at high risk of developing that condition and to be able to advise them to stop playing sport. And to do that with enough certainty that they would take that advice. Do we have that certainty in our armamentarium? So they're the questions that I'm going to address in this lecture. How do we go about that? Well, there's a number of studies that around the world that are looking at these in what is really the only design of study that is amenable to answering these questions. And the three largest ones are the TRACK TBI study from the United States, the CENTER TBI study in Europe, and preceding them both the TBI impact study that was coordinated, well, really all around the world, that's created a very large database that's enabled us to, amongst other things, come up with some really quite accurate prognostic models for traumatic brain injury. So we'll start by looking at severe TBI. And one of the first prognostic models used the data that was accumulated during the CRASH randomized controlled trial of steroids for head injury. And this is a calculator that's available on the internet. You can go to it now and put in all of the variables you can see there on the left-hand side of the screen, and it will give you an accurate estimation of the 14-day mortality and the risk of unfavourable outcome at 6 months. An even more complicated or intricate, you might say, prognostic calculator is that impact TBI calculator, which again has been translated into an online form, and you can see the variables there on the right-hand side of the screen that include age, motor score, some clinical criteria, and some CT criteria as well, and some laboratory criteria. And putting all of those things together gives a good area under the curve predicting functional outcome at 6 months. But both of these predictive algorithms, and indeed everyone that's been published, has always been published with the caveat that they're useful for risk adjustment, for clinical trials, for quality assurance, and so on. But they're not sufficiently accurate, you might say, to be able to be used for treatment limiting decisions in individual patients. And that's what clinicians are really hoping for when it comes to potentially adding biomarkers. And an example of how these things really shouldn't be used for individual patients is this very nice paper published by the Menon group from Cambridge that compared two patients who, on the left, as you can see, had very similar characteristics at their baseline. If you plug them into these risk calculators, as they did on the right-hand side there, they came out with very similar risks of an unfavourable outcome at 6 months. In fact, the patient 2 there looked as though they would have had a higher risk of an unfavourable outcome compared to patient 1. And yet, as things panned out at 6 months, patient 2 did substantially better than patient 1, highlighting the fact that these shouldn't be applied to individual patients. So can we look to biomarkers to improve this? Well, people have looked at that extensively, and this is a nice systematic review summarising very, very many papers that have attempted to do just that. You can see the areas under the curve of prognosticability of each of these biomarkers with fairly good areas under the curve at greater than 0.85. But is this good enough to make decisions in individual patients? And I'm sure any of you who've looked after those individual patients would say no. So really, the answer is probably not yet for biomarkers in severe TBI. What about chronic repetitive traumatic brain injury? This was a study of ice hockey players who were concussed and then had biomarkers assayed in their blood at baseline and then over a period of a week or two after that injury. And they were able to correlate the degree of neurological symptoms acutely with the level of tau and S100B, two biomarkers still in common use. So that's interesting. It showed that there was evidence of neurological damage, having had concussion playing ice hockey. But what we're really interested in is whether there's utility in these biomarkers predicting long-term outcome, whether you should tell these ice hockey players that they should stop playing ice hockey. We've been similar studies in the military and people exposed to chronic blast where, again, there's a tight correlation, or relatively tight correlation between biomarkers and acute symptomatology. But relatively few studies have then gone on to look at the correlation between those biomarkers and long-term outcome. This is one that tried to find such a correlation and was unable to do so. So looking at people who'd who presented to emergency departments, 35 subjects with mild TBI who had biomarkers taken and then followed up at 3 months on a concussion score. And as you can see on the two graphs there on the right, essentially no relationship between those two variables. So really it would seem that in mild traumatic brain injury, the predictive ability for concussive symptoms is really quite poor, and really no one, to my knowledge at least, has looked at the predictive ability for chronic traumatic encephalopathy. So at the moment at least it would seem not possible to use these to do anything like tell people that they should stop playing sport, for example, because they're at risk of CTE. Probably the thing to do is to monitor these biomarkers over time, and there've been quite a few studies looking at the time course of these biomarkers, and I'd point you towards this paper again from the Menon group, looking at how each of these biomarkers differs in its time course of resolution. And then lastly, looking for patients who potentially need further investigation after they present with mild traumatic brain injury. There's a number of clinical rules. This is the Canadian CT head rule that classifies people who present to an emergency department after a mild traumatic brain injury into people who should and do not need to have a CT scan. And a well-validated rule that, as you can see on the right there, if people do not have any of the high risk factors, then really those high risk factors are 100% sensitive for predicting the need for some sort of neurological intervention. And by the application of these rules, a large number of patients who would otherwise have required us or have had a CT scan will avoid that CT scan to a great cost saving to the healthcare system. The United States, the American College of Emergency Physicians have a similar set of rules, but very interestingly in their rules, they incorporate S1B, a biomarker, as a means of excluding people who require a CT. And these were written some time ago, and there's a very interesting study that's been published subsequent to that, looking at GFAP and UCHL1 as biomarkers to exclude the need for people to have a CT who've presented after TBI with a GCS all the way down to 9 and up to 15. So nearly 2,000 patients with those GCSs down to 9 who were thought to require a CT for clinical indications. And so they did actually go on to have that CT. The study didn't interfere with that. But they also had their GFAP and UCHL1 levels measured. And as you can see on the graph there, the patients who had positive CT findings had significantly higher biomarker levels, as you might expect. So that wasn't necessarily the surprising finding. But what was potentially very clinically interesting was that patients who did ultimately require some sort of neurosurgical intervention, of whom there were relatively few, only 8, were essentially indistinguishable from the other patients on clinical indices, as you can see in the table on the right there, but were very clearly distinguished from those patients, from those other patients using the biomarkers. And so the negative predictive value of the combination of those two biomarkers was very high for any form of neurological abnormality, and 100% for avoiding the need for, or at least detecting neurosurgically requiring lesions. And what's more, by applying this rule, a third of head CT scans can be avoided. There's just one more point to make here, and that is that this isn't all just about avoiding imaging in mild traumatic brain injury. This is a later study from the same group that identified patients who had normal CT scans, but who subsequently went on to have abnormal MRIs, and so people who you would be concerned about. And these people would have been missed because not everyone gets an MRI. And by using the biomarker, they were able to identify people who should go on to have that MRI scan. These tests can now be done on point of care tests, and so really very simple to implement in the clinical environment. We're doing a similar study along these lines in Queensland with cell-free DNA and advanced MRI imaging. So we hope to contribute in our small way to these very large studies that I mentioned earlier. The bottom line, though, is that for the moment, blood biomarkers, yes, do improve potentially the predictive ability in severe traumatic brain injury, but probably not sufficiently to make individual decisions for patients. Yes, they are abnormal in patients exposed to low-intensity brain trauma, but really whether that's enough to make decisions for individual players, for example, to help them avoid chronic traumatic encephalopathy is not sufficient. And then lastly, there's now really quite good evidence, admittedly from a relatively small number of studies, showing that both biomarkers can avoid the need for scans in many patients, but also indicate MRI scans in patients who would not otherwise have had them. Thanks very much for listening.